everyone. Hope you're all doing good. Guys, I want to welcome you to again now the most trending RRR series, which talks about read, revise, repeat. So today's topic is all about the most wanted topic, most wanted module, clinical governance. Let me see how can I make this easy and fruitful for you. Okay. So yes, definitely our vision for you has always been definitely to help you achieve your dreams and probably make your dreams to reality. Your success is our mission. So just visualize that you have already passed the exam and you would be there. Definitely, you would be there. So let's start with the clinical governance, starting from the training, because this is a very important basic which everybody has to understand. As you know, in the UK, the training system starts from foundation year 1 to ST7. Okay. And if at all, if you have to move from ST2 to ST3, you must have cleared your Part 1 MRCOG. And if you're moving from ST5 to ST6, it's a must that you must have cleared both Part 2 and Part 3 MRCOG. This is for the academics. There are a lot of other training system which works for different assessments, which we will be talking in a while. And so once you finish Part 2 and Part 3, you enter into advanced training. Ideally, foundation year training is a year 1 and year 2 where they have a rotations, and then they get a national trainee number, which is an NTN. Then the basic training is ST1 and ST2. Intermediate training is 3, 4, and 5. So ideally, for your exams, you are considered as an intermediate in the process of intermediate training. And advanced training is ST6 and ST7. After that, of course, like once they reach the ST6, ST7, they would be having advanced training specific modules to be done. And obviously, then they can choose a subspecialty and then so on from then onwards. Okay. Let's move on for the next one. So who will be the educators throughout the training system? This is something which actually people are, for the overseas candidates, this could be a little challenging because we haven't gone through this process. So there are different types of educators, but the most important person for us is an educational supervisor. Okay, so educational supervisor is somebody who will be like guiding the trainee attached to them from the beginning till the end. Of course, then you have the college tutor, TPDs, that's the training program director, director of medical education, then head of school, deanery. So there are different levels, but the trainee is closely in touch with the educational supervisor. Coming to the most asked question for me, what are the different roles and responsibilities of different at different tiers? So let's talk about the educational supervisor. As I said about the educational supervisor, he's the one person who will be closely working with the trainee to make sure that he does the required number of assignments. Please remember to move from one level, ST1 to ST2, ST2 to ST3. They have to be doing minimum number of assessments and which would be given in the portfolio. So all the trainees have to maintain e-portfolio. So that's the reason they need to know, like, because that is what the assessors would be looking at in annual ARCPs, so that what are the minimum assessments you have done. So the main role of educational supervisor is to guide the trainee to finish their minimum required assignments and assessments to move from one to the other. Okay, as well, it's very important to make sure that the authenticity of the documents provided, and they have to make sure that the trainee is well gelled, because they keep talking to them like there is something called an induction training. Once the trainee enters into the training, they would be given a path what to follow, and like every 4 months they meet the trainee to understand where they are doing and where they are going and any difficulties they have, and that is the time when they will be assessing and talking about how the improvement for the annual assessments. Obviously, these are the educational supervisor is the primary point of contact for a trainee for all this. Okay, so that the candidates are doing their assignments, assessments, and it is definitely the candidate who is doing its candidate's own thing, as well as if they have concerns about work level of practice, like probably if it could be bullying, it could be training difficulty. These are the ones which should be reported to the educational supervisor so that he can take it further and help the trainees. Obviously, apart from that, the clerical job of making sure that they are signed up for the particular module which is required for the year, and any forms required, they would be able to sign. Okay, so now let's move to the medical director. The medical director is a person who will be basically he is bridging a gap between the staff, medical staff, and the board. Okay, and obviously he will also have a major role in terms of maintaining the clinical governance and educating and medical training, all those things. Basically, medical directors are the one who will be providing the clinical advice to the board as well. And if there are any disciplinary action against the concerning doctors, that job would come to the medical director. When I come to the clinical director, so what role the clinical director has? Clinical director, the prime job is to take care of the patient care, but also if there is any legal and administrative aspects of the facilities. For example, if there is any epidemic or pandemic like COVID, okay, how to arrange the units, how to work around, how well the doctors can be managed during that time, the workforce, all those things would be taken care by a clinical director. Obviously, they will also be making sure that the departments work in compliance with the policies and the guidelines and the standards. And they have a major say in clinical budgets and the payroll as well. Okay. So these are the bridge between the patients and the families and the additional care staff the clinical director would be taking care along with the doctors and the patients. Now, those are the three people whom the roles and responsibilities you should be knowing. Of course, the rest of the thing, like the college dean and the training program director, everybody has got an individual responsibilities, but these are a little tricky. That's the reason I spoke about them. Now, how would the college maintain that every trainee who finishes the training is equal and uniform? For that, you have got the assessments which are formative and summative. So what is the difference between formative and summative? Formative is a friendly feedback to help students to learn and practice. Summative is where it is like an exam. Okay, so you are going to give your exams, which the results would come as pass or fail, and that is what is summative. But whatever the internal assessments you do, it is a formative assessments where you still get the time to correct yourself and how to improve and how to work around. But summative assessments, because you all have already finished your like friendly assessments and you have done your mocks, so now the goal is to prove that you deserve to pass this exam. Okay, so that's the basic thing, and of course you get a grade like pass or fail or things like that. Okay, now why am I trying to tell you is there is the work-based placed assessments. You need to know what are the assessments which a trainee has to go through. So there are lots of different words and you need to know about different assessments which you need to be familiar with and what type of assessment it is, because it's an important single best answer as well. So let me talk about each one of them. The first one is mini KEX or mini clinical exercise, which is a formative one. Again, probably the examples you can take it like a gynec examination or taking a consent. Okay. Only one thing I want to mention here, unless you have been signed off to do the procedure, you won't be able to do the consent part. Okay. Next is CBD. CBD is case-based discussion. Because as a like a clinician, you will be managing a lot of cases. So you should have a chance to discuss with your seniors how well you have managed or probably was there any scope of improvement. And that's why it is a case-based discussion. When you move for technical part of it. So these are all the like step-by-step approach to make a trainee better. So for the technical skills, let it be like a suturing or the knot tying, simple procedures, probably suturing from episiotomy to complex gynecological surgeries. We all need to be supervised, assessed, and signed off. So that is what you would be doing in OSATs. OSATs is objective, structured assessment of technical skills. Okay, so again, nobody should be given direct summative, right? So it would be a formative assessments first, where you learn, unlearn, and probably become the, like, you know how to do exactly each of the procedure from skin to skin. Then you go for a summative assessments. Okay, so once you have done a formative, then it is summative. Only a thing about OSATs is it has to be done by 3 different assessors. Not one person cannot sign all the OSATs, and one should be from a consultant. And definitely, before you go for OSATs, you have to be telling the assessor whether you are going for formative or summative. Okay, and you cannot change. For example, you did really well the formative assessments, but you would want to flip that to summative, or vice versa. You came for summative, it didn't go well, you want to change to formative with your assessor. That is not allowed. Whatever you have signposted way before starting the procedure, that I'm here for formative, so formative OSATs would be signed. If you're for summative, summative OSATs would be signed. Okay. Next, ARCPs. ARCPs is annual review of a competency. Like 1 year from ST1 to ST2, when you have to move, they need to know, like, 1 year, what are the things which you did with all these assessment forms. Okay, there are still more which I'll be talking about. So you will be submitting all your assessments to your educational supervisor, who will have a look, and then probably then the trainees also have a say to understand how will they have done this year, and then it would be submitted to ARCP panel. ARCP panel is 100% summative. They give you the grades or the outcomes, whether you're good to move to the next or you cannot move. Okay. And yearly, this is yearly for everybody. So once, this is all for the trainees. Once you become consultant, is it a must that you need to be doing something about like showing your assessments, or showing your, or making sure that you are still doing the best of the jobs? That is the reason the appraisals, the consultants go yearly appraisals, which is a summative one. And for GMC, if you are a GMC registered, the General Medical Council registered already a person, doctor, you need to prove yourself that you are still fit to practice, which is a revalidation, which happens once in 5 years. So revalidation is to show that you are still fit to practice medicine, and it happens once in 5 years. Okay. Hope this helps, and these are very important questions for your exam. Now, the similar ones which generally in the exams it has asked, as you all are aware, part 1, part 2, and part 3, they're obviously the summative assessments, right? Definitely, there are like they have got SIPs and all, which I haven't included. You should, if you get a time, you can just go through what are the SIPs which need to be known for 1, 2, and 3. Obviously, it is not important from the exam point of view. And when you come for workplace-based assessment, assessment of performance, OSATs, remember, it could be formative and summative. And case-based discussion, as I mentioned, is like CBD is the same thing, mini-CACs, and non-technical skills for surgeon. See, non-technical skills, I have a complete slide about it, which I'll be talking. These are the softer skills. And OSATs, as you know, OSATs could be summative, it could be formative. Then, this workplace assessments, like before, there are 2 words. One is for formative, you can call supervised learning event, okay, instead of formative. And for summative, you call assessment of performance, because that is what it is, right? You are assessing a performance. Here, you are supervised and you are learning. That's why formative is a supervised learning event and summative is an assessment of performance. Now, these are all encounter based, like including the notes. People see what is your decision making, whether you're calling for help, whether you are coming in whenever you have been called for help, those things. But there are something called not encounter based, like team observations. Okay, team observations is, for example, you have been, as a doctor, you have been working with a lot of people, from porters to midwives to anesthesia technicians to, like so many people. So they also have a say to understand how good holistically you are, how well you gel with the team and things like that. Okay, so that is what is called TON forms. So for every appraisal or for every ARCPs, you must be submitting 10 team observation forms from different people. And this is what is called TO1. Okay, when you submit the TO1 form to your educational supervisor, the 10 forms for ARCP, he would calculate the score, and that is what called team observation 2. Okay, so this is what would be discussed in the ARCP panel. I mean, ARCP when they submit. Self-observation to understand reflective practice, which is called like where you can decide how well you have done. Okay, so those are the important forms which you need to be knowing. Hope you're all enjoying this, guys, because it's something which as an overseas candidate, we always find it challenging. But remember, clinical governance is just a medical common sense. What about NOTS? NOTS is a non-technical skills for surgeons. Obviously, it has 4 things. One is situational awareness. Like, for example, you are assisting a cesarean section, or you are assisting any surgeon, any surgery, or you are doing any surgery, you verbalize and you think what is going to come next. Okay, you can say that, okay, the additions are more, sister keep, or the probably whoever is a nurse the assisting, you can say that to keep the additional instruments, or probably you ask your consultant to be around, those things. And that is what the situational awareness is, to understand that there could be difficulties. Communication and teamwork, you have communicated to the scrub nurse, you have communicated to get the consultant on board. Decision making is again probably the same decision to call rather than thinking it late, and taking the leadership skills. If at all, if there is any issues, for example, there was a bowel injury during the cesarean or probably during the abdominal hysterectomy, how you identify, how you manage the whole thing, calling the multidisciplinary team for help, all those things. So it's basically a softer skills, nothing to do with your technical skills. Okay, so this is what it is given a huge importance in e-portfolio. So you guys need to be knowing, because if poor knots means they would straight away begin outcome of 3, which I would talk about in a while. Okay, perfect, guys. Let's move on. This was one which I wanted to speak, which I was trying to tell you, ARCP outcomes. Because every year when you submit the documents, obviously you need to know what are the different outcomes available. Because you need to know, because if you are the candidate who is training, who has applied for the ARCP, you need to know whether you can move to the next year or not, which depends upon these outcomes. Okay, so what is outcome 1? Outcome 1 is a very good outcome to get, where there is no backlogs. You can move to the next year very easily. For example, you are an ST2, you get an outcome 1 and you move from ST2 to ST3 without any hazards. This is the one which every trainee would wish for. Next, what is outcome 2? Outcome 2 is, they mentioned there is a deficiencies in training, need target training, but it doesn't need extension of training. For example, if a person is not very good at particular skill, for example, let's take a skill of MRP, okay, manual removal of placenta. This person is really doing good in formative, but when it comes to summative, because of the less cases available, he or she is not able to perform. So in that case, what they do is, outcome 2, you still move from ST2 to ST3. However, you would be needing additional extension of training for that particular thing. Okay, so that's what they mean, rather than holding you at an ST2 level. Perfect. What is outcome 3? Deficiencies in training and addition, which needs additional training and need extension of the training. This is the keyword, and need extension of training. That means to say, you cannot move from 2 to 3 unless you finish those deficiencies. So you will be staying back at ST2. This is what happens if somebody has not cleared their part 2 and part 3, they cannot move from ST5 to ST6 unless they clear the exams. Irrespective of how good clinician you are stuck at that level. And that is what is outcome 3. Okay, and any repetitive bad behaviors would also come for outcome 3, because those are softer skills are considered much more value than the technical one. So if something happens once or twice, it's okay, but if it is repeated, they get outcome 3. Okay, fantastic. What is outcome 4? Outcome 4 is, you have trained, you have given enough chances for this person, but irrespective of the chances given with additional training, with the deficiency of the deficiencies identified and given a chance, this trainee is not up to the mark. It is still unsatisfactory. This is the last one which they would be giving, which is outcome 4, that they are released from the training. Okay, this is not definitely a good thing to get. What is outcome 5? Outcome 5 is your ARCP panel is not able to come to a decision because you have not submitted the correct documents. So you have to be submitting the documents required to get an outcome. Next, outcome 6 is a very satisfactory one. So you can proceed to CCT, that is certification of completion of training. After that, you are a consultant. Okay, guys, this is a very important slide because you would be getting questions on this. Hope it is helpful. Perfect. Couple of things which I wanted to bring your attention to. As I said, if they are very good clinician, but they haven't passed their academic path, for example, ST2 didn't clear part 1. Obviously, he or she has to stay back in ST2 level only, and that's where you get outcome 3 till they finish. Next one, ST2 trainee has demonstrated good formative OSATs, failed 3 summative OSATs as she has less exposure. Rest of the things she's fine. About particular procedure, because she's getting a less exposure, she is not able to do it. In that case, what would you do? Obviously, in that case, you give an outcome 2. That is, she can move from that 2 to 3 or 3 to 4, whatever. However, she has to have an additional training. And then comes the negative comments in the TON forms. Remember the team observation forms, which I mentioned before. If there are very poor or the negative comments, then you get a poor TO2 score, then it is outcome 3. So the trainee has to stay back in that particular year only. Like if he or she was supposed to move from 2 to 3, if it is poor TO2 score, they would be getting outcome 3. Obviously, they have to stay back there. And trainee applying for CCT, which outcome he has to get? Outcome 6, which I explained. So basically, these outcomes are based on technical and non-technical skills. That's including, it's a holistic approach so that the trainees get the best of their outcomes, concluding everything. It is not that you cannot be thinking that I'm a very good surgeon, so or I'm a very good clinician, no need to bother about anybody. That doesn't work. Softer skills are very important. Let's move on. ARCP specific outcomes, outcome 2 and outcome 3. Where do you get what? I want to draw your attention to this. Okay, so the first one, work-based assessment, when the CBDs and mini-cakes are sufficient, the numbers are sufficient. It depends. Sometimes it's 3, sometimes it's 5, depending upon the e-portfolio and the procedure you have been opted for or the year which you are in. So basically, if their numbers are good, but the quality is not very good, then they would be giving outcome 2, where they are supposed to be getting an additional training and do the things. But when the number is completed, when the number completed is below that noted in the matrix and persistent, inappropriate timing and quality, when it is repeated, you get outcome 3. Again, the next thing is also about the courses, because you are supposed to be attending specific courses like the BPL, basic practical skill course, prompt course. So if at any way out point, if they do not do this, they are supposed to be getting outcome 3. And any point of time, it is not once. Okay, some concerns by ARCP panel, they would give 2, but major are the recurrent issue noted, they would be getting outcome 3, where they cannot move from that year to the next year. Okay. Perfect, guys. Now let's move to the random scenarios, couple of random scenarios. A foundation year 2 doctor, probably 1 or 2, it is not 3. So foundation year 2 doctor on the flight, when a 40-year-old suddenly felt giddy and had a chest pain in the flight. So the doctor comes up to the patient. The point is whether this junior doctor is protected. Definitely. First thing is the junior doctor has to treat the patient on the flight because that's our basic duty. But if something goes wrong with this patient, this doctor won't be in trouble because you are actually doing this on a humanitarian ground. Next, this I already discussed, pandemic like COVID, who will be taking the responsibility? It is the clinical director. Then a particular trainee doesn't attend any pager calls. He doesn't attend any emergency calls in our labor. He is here for ARCP. Remember, this is something to do with non-technical skills and it is repeated. Obviously, they get outcome 3. Next. Jehovah Witness, 17-year-old placenta previa with bleeding, Jehovah Witness with hypertension and tachycardia, not willing to take blood. Just to give a quick recap, Jehovah Witness are the religious group who doesn't believe in taking blood from others. They can, at some point of time, they can take few blood and blood products, but it has to be, you have to discuss with them. But they do not take the blood and blood products generally. So giving a blood and blood products to Jehovah Witness is a battery. Now here the challenge is she's a 17-year-old. Remember, the legal age to called adult in UK is 18 years. Okay, so if anybody less than 18, and this is the only exception in Jehovah Witness, where less than 18 years is like a Jehovah Witness and she's having to save her life, you can override. Obviously, you have to take the 2 consultants' opinion, but it can be overridden. And obviously, more than 18 or more than 18, if the patient has given a written advance directive that you cannot give blood and blood products, you will not be able to do. What they take is their own blood, which is autologous blood transfusion. Or you can say that intraoperative cell salvage. Through that technique, you can give the same blood. How many appraisals should a doctor have in one revalidation cycle? Remember, revalidation happens once in 5 years. So obviously, the answer is 5. Okay, perfect, guys. Let's move on. Again, couple of important points about few scenarios which they could ask you. And these are the general things which are usually you can come across if you're working in NHS. Trainee using a cocaine. Okay, so definitely this is a serious offense because we are talking about cocaine. Okay, even alcohol, drugs is very serious. Obviously, alcohol also, no doctor, no trainee should be caught with that. So they should know the ethics and duties when they are on duty, when they are treating the patients. So this is definitely a serious offense. So what they do is they inform, if you have been trainee who have seen this, you inform to educational supervisor or training program director or deanery. The first one, they give a strong written warning. If that person repeats again, obviously he'll be out of the system. Okay. The second one, woman has been diagnosed with cancer cervix. Okay. And she's, her screening reports of a severe dyskaryosis was not communicated. Okay. So that is not correct, right? So like, because it was not communicated, as she moved from one place to another place. Ideally, a leading colposcopist nurse should have the change in address and all that. Just because she was moved from one address to the other address and it was completely missed to communicate and she has come back with cancer cervix. Obviously, this would generate a root cause analysis to figure out why, what happened, and they didn't inform. Next, the many cases of ureteric injury in post-hysterectomy cases in your unit. The buzzword is many cases. If it is one case, you do root cause analysis. If it is multiple cases, you do audit. Okay. Audit is to measure the practice. The next one is trainee had taken case notes for study purpose home with patient who had a private info of the patient and study papers were stolen. Generally, this is a question which has been running in circles. So if you have, obviously all these things, the incident reporting should be done. If you have an option, reporting to information handling committee, please go for that. Okay, so that's what I've written here. The next one is a sepsis with retained products in women who has undergone surgical termination, because this can happen because surgical termination also there is a possibility of retained products. However, the point was she said no one informed when to come because that's a communication gap and it's a serious thing. So obviously you have to be doing a root cause analysis. And then a trainee in difficulty. For example, somebody who was very good right now, he doesn't attend the calls, he doesn't come to the work, and he's always very silent, and he keeps on pushing his work to somebody else. He keeps on doing the disappearance act. Definitely, your educational supervisor is a prime contact who will talk to him or her, probably based on their personal, social, financial We don't know what is the issues. So they would be talking and taking it from there. Okay, hope those scenarios have helped you to understand a bit about how the system works. Next. So this is a very important thing because between 13 to 16, 16 to 18, and more than 18, how do you go about? Okay, so if let's look into this scenario. 15-year-old girl attends outpatient clinic with a stepmother who has not adopted her. Her father, who has only recently remarried, could not attend the appointment. Patient is due to have a laparoscopic cystectomy for an 8 centimeter dermoid cyst in a week. The consultant has deemed the patient to have the capacity and has explained the procedure, risk, benefit, alternatives. And also to her and her parents on a previous clinic visit. Both father and stepmother support the patient decision to proceed with surgery. Now, who has to give the consent? Okay. So here the thing is, if the patient has a capacity, because the consultant has seen that the patient has deemed to have the capacity. In that case, you just need to take the patient's signature. If the patient doesn't have the capacity, then the father is the one who will be giving the consent, because biological parent is the one who will be giving, not the stepmother. Okay. Generally, if the between 13 to 16, if the patient has got the capacity to accept procedure, then you will go with them. The next one. What is the most appropriate management option if you were the consultant in charge of care? Generally, if you have a single best answer, which is a lengthier one, go for the last sentence and then read the scenario. Okay, a 38-year-old lawyer, 34 weeks into her first pregnancy, developed preeclampsia. Her blood pressure is inadequately controlled on 2 antihypertensives. Most recent scan shows severely IUGR baby, estimated fetal weight less than fifth, okay, reduced like a volume by 4.2, and raised Doppler's umbilical artery. She has capacity and is declining steroids and delivery by CS within the next 2 weeks because she believes everything will be fine and should be liking to avoid the surgery. This is an ethical situation, ethical dilemma where you want to do good to the mother and the baby. However, the mother is not willing. She has her own belief system. The first and foremost point what you would be doing is you would explore her concerns, why, how, what, and definitely check her capacity about mental capacity. If she has got this in practical things, you would be referring to the consultant to have a word as well. However, the bottom line is if she has a capacity, the unborn baby has no right. So you have to respect her wishes and do a regular follow-up. You might have two options. One is respecting the woman's wishes, the other one respecting the woman's wishes and ensure regular follow-up. Then you have to be going for this. Remember, mother has a say because once the baby is born, it is an individual, but unborn baby has no right. Okay, let's move to the consent main points. The legal age to consider as adult. For example, if they want to sign any forms, okay, like Jehovah's Witness form, like advance directive form, or legal power of attorney, anything of those sort, it has to be 18 years. The challenge between 16 to 17 is it's a gray zone. They can accept any procedure. Okay, when you're talking to a patient, if they're able to understand, weigh the pros and cons, and talk back to you their communication, they mean to have the capacity. However, if they accept, well and good, you can take their consent and proceed. If they do not accept, okay, the treatment which is necessary, then you can override their consent. The point is they can accept, they cannot refuse what is necessary for them because they are still less than 18 years. Jehovah's Witness for adult, do not accept any blood products because it's battery. As I said, for adult means 18 and more. For children, can give in emergency. The consultant would talk with another consultant opinion and proceed in the best interest. If it is an elective case, you can take a court order. Do the procedures consented? Definitely yes. You have to be doing the procedures which is consented unless it is life-threatening for the patient. Biopsy doesn't need a consent. Elective procedures. For any woman who is undergoing elective procedure, you need to give enough time for her to think, to see the pros and cons, and that is what is called cooling off period. Women in labor refusing the procedure. You have to always assess her pain and see why she is refusing. And if she has the capacity and if she still wants to she doesn't want the procedure. As I said, you have to agree and respect her wishes. And as the rule goes, unborn fetus has no right. Okay. This is what I wanted to tell for Jehovah's Witness for children. Child's refusal for blood transfusion is not valid if this decision has been made under influence from others. We don't know. This is the point why you don't want to leave them thinking that, okay, they are Jehovah's. For the children, this doesn't hold good. That means less than 18. Now, couple of things. 16-year-old girl staying with dad, unmarried parents. She came for abortion and she agreed for abortion. Like she stayed with dad, but her parents are not married. So whom you have to encourage to, because generally you inform them to, like you encourage them to inform parents, right? So should she inform her dad because she's living with dad, or should she inform her mother? Okay. The point is, it is her wish whom she has to inform. Your job is to encourage her to inform. Okay. And of course, if she has a capacity to consent, it is not a legal requirement that she has to inform either of the parents. Now, SD7 is all set to be specialized, very few minimal things left in the process. We know this. It is ARCP 6, right? Outcome 6. Next, a trainee was recently involved in management of case of massive postpartum hemorrhage. As a trainee educational supervisor, you would like to assess the skills of the trainee with respect to management of postpartum hemorrhage. So what is the tool which you would be using here? Case-based discussion. Remember, I spoke about heavy menstrual bleeding, PPH, shoulder dystocia, whatever they have managed. They're going to sit with the educational supervisor or the consultant and talk about it. Next thing, which aspect of clinical governance is characterized by following definition? Quality improvement process seeks to improve the patient care outcomes through the systematic view of care against explicit criteria and the implementation of change. Obviously, it's very clear. It's a clinical audit. So remember, research gives you the lyrics to sing the song, but audit checks whether you are singing in the right tune and whether you are using the right lyrics. Okay. Let's move on. Consent, because you get a lot of questions on consent. So that's the reason I have added all this. Consent has been given only for hysterectomy, left ovary as suspicious mass. Okay. What do you do is you take a biopsy. Obviously, you don't need to have a consent for a biopsy. Okay. And obviously, if it is too frozen or something, you can always even take the omental biopsies, peritoneal wash. So that because you're seeing a suspicious mass. And to proceed with hysterectomy, if you're suspecting cancer, obviously it depends on the scenario, but just answer to the question asked. Open for twisted right ovarian cyst, normal ovary, but found inflamed appendix. Consent has been given for cystectomy or oophorectomy. Very common. You have your surgeon might be calling you for cyst, ovarian cyst, or you might be calling surgeon for the appendix. Obviously, you have taken only consent for cystectomy or oophorectomy, but there is a twisted right ovarian. The ovary is normal. You open thinking it's a twisted right ovarian cyst, but it's a inflamed appendix. Obviously, because the ovary is normal, you have to do nothing, but you will call for surgeon. Obviously, that's a protocol, and they would be going ahead with appendicectomy. That is their choice, the surgeon's opinion. We cannot comment whether they have to go ahead or not because the specialties are different. What would you be doing as a gynecologist, your ovarian cyst, for the ovary, normal ovary, because it's normal ovary, you don't do anything, you just leave it like that. Open for suspected appendicitis, but you think simple, but the surgeon saw simple ovarian cyst. Obviously, your surgeons will call, you will go scrub, have a look, and if it's simple ovarian cyst, you would just call them for follow-up. Open for suspected appendicitis, but your surgeon saw dermoid ovarian cyst. Obviously, they would have taken consent only for appendicectomy. Then you would say that for ovarian cyst part, unless it is torted or gangrenous or anything serious, you would ask them that they can send her back later on during the follow-up. Okay, so remember to do the procedure, whatever they have consented only, you should be doing. Now, this is which I said before, the consent between 16 to 17. Unlike the adults, the refusal will not be taken if it is in the best interest. You will, if the child refuses, you will ask the parent. If the parent refuses, then you will ask both the parents. If both the parents refuses, then if it is emergency, the you can proceed with the best interest. If it is elective one, you can do with the court order. Okay. So it is definitely not a legal necessary to obtain the consent if the patient has a capacity. Okay. Yes, but you would always include the patient's family. It's a good practice, right? Now, yes, this I already told you. Patients disagree with each other, court involvement could be done. Yes. And remember, mother automatically has a legal parental responsibility, but unmarried father also has a full automatic responsibility. It is not that whether they are married or not, they still hold the same parental responsibility, and divorce doesn't annul the father's rights. Now, couple of things again for the consent. I've added a lot of things for consent because people get really worried. 16 years found to have capacity, refusing lab for ectopic, mother is willing for surgery. Emergency, so take the mother's consent and proceed. 16-year-old competent for appendicectomy, she is willing for surgery. Is it legally required to take consent for parents? No, not required. The next one, 17-year-old, 39 weeks, doesn't Jehovah's Witness, doesn't want to receive any blood products. She doesn't have any, she doesn't want to have blood products even if she ends up in life-threatening hemorrhage, because this girl is young. If it is emergency, you would be going ahead and giving. If something arises, elective case, take a court order. Okay, be safe. The next one, 16-year-old operation for appendicectomy, both parents are not willing, girl has no capacity. This could be another scenario where the child doesn't have a capacity, but the parents are not willing. What would you do then? Obviously, emergency, proceed in the best interest, elective, take the court order. The next one, 15-year-old for ovarian cystectomy, doesn't have a capacity. She is accompanied by her mother and stepfather. Obviously, you take the consent only from the mother. Few more things, guys. Patient consented for lap hysterectomy with a past history of dermoid cystic mole. Intra-op surgeon finds dermoid cyst 4 cm adherent to the pelvic wall in the ovary. So here the challenge is, even though they have undergone a procedure before, but the patient has given only consent for hysterectomy, then you have to be only doing hysterectomy. You cannot remove the cyst thinking she might have to go for the other procedure. No, remember, it has to be done unless it was a gangrenous cyst. Okay. Next one, appendicitis was found normal. There is a torted, okay, they opened for appendicitis, but laparoscopy appendix was normal. But there's a torted ischemic right fallopian tube with watery discharge. So this is gangrenous tube, which you need to be removing. For this, you proceed in the best interest. You will not be waiting for the consent. Obviously, appendix, what they will be doing, that is surgeon's job. You have to comment on the tube. The next thing is labor pain, transverse line needs surgery. She knows very little English, and her husband, she's accompanied by her husband's cousin who was translating to them. And she said she doesn't want cesarean section. Okay, the patient's relative has been being the interpreter here, and she's refusing the cesarean. What is the thing you would want? Obviously, you will respect her wishes, but please make sure she understands what you are trying to tell her. It has to be through a professional interpreter, because you cannot use any family members as an interpreters. Very important and a valid point. Next, abnormal CTG, refuse CS and doesn't want cut in her tummy. She has a past history of psychosis and now diagnosed as mania. Here, the major challenge is she has lost her mental capacity. Okay, so what you would look in is whether this patient has got an advance directive before losing her capacity, whether she has written down that I never want to have a cesarean irrespective of my situation, before she developed psychosis or before she had this been diagnosed of losing the capacity, that holds good. If not, if it is an like emergency, consultant opinion would be taken and they would be proceeding in the best interest. Elective, you take a court order. Very interesting scenarios, because you need to know the basics so that you can answer very well. Next, very important, HIV and the clinical governance part. HIV positive pregnant woman, she doesn't want to take retroviral, ARTs, antiretroviral. Obviously, You will respect her wishes because it's her autonomy. It's her body, her infections. But I know you are worried about the baby, but unborn baby has no right. On the other hand, she doesn't want child to be treated postpartum. That is not possible because the child, once it is born, it's an individual. So you take the court order and proceed. She wants to breastfeed the baby at any cost. So that they obviously, I'm giving a hypothetical situations. It depends upon the viral load, everything. However, they cannot be forced, like probably she is trying to do for her social circumstances or whatever. In that case, she cannot breastfeed. You have to counsel her, you have to explore her concerns. In spite of that, if she wants, then the safeguarding committee has to be informed. At times, what happens, they can take away the child. So that is something which the mother has to understand. And now she says she doesn't want the partner to know her HIV status. See, these are sexually transmitted. Probably she's worried she can get separated from her partner, X, Y, Z, whatever the reasons, but you cannot put her partner's a partner at risk of developing HIV. So you will first explain her to like she can actually reveal to the partner, the patient herself. If she is not willing, you have to still notify the partner. There are a couple of things where confidentiality is not maintained, like HIV, road traffic accidents, and the bomb blasts, terrorism, all those things, the confidentiality is broken without even taking the permissions. Hope this slide you found it interesting. Few more. What is the formative tool assigned to provide the feedback for the trainee about their performance in some or all areas of this clinical counter? It is definitely a mini KEX when you're talking about a couple of, obviously the scenario you would, when they give you the complete one, you would know. And the next one is Dahlia, 26-year-old, appendix posted for appendectomy. Appendix is healthy, but right simple ovarian cyst, measuring 5 to 4 centimeters found. Gynecologist called for opinion. What is the appropriate management? Similar one, but in different ways. You haven't taken a consent, so abandon the procedure. Abandon the procedure for, you won't talk about anything about the cyst, okay? You will discuss with the cyst management later in the OPD. Obviously, you would only be doing procedures consented unless it is life-threatening. Next one, previous 3 CS. On the day of her elective CS, she says that the previous, she would like to have a concurrent sterilization. You look back into the notes and notice that all her previous CS have been very difficult due to dense abdominal adhesions. You notice that in her previous appointments, no healthcare professional has discussed the sterilization. Very dilemmatic situation. You know that if you don't do the sterilization, she can become pregnant again. And probably even if she comes back for the next procedure could be difficult. However, whatever said and done, she is telling you on the day of her surgery where she has not been given a time to think. That's the cooling off period, and nobody has discussed the pros and cons so far. So you cannot do the procedure. You have to politely refuse. You have to give, because sterilization is not a life-saving procedure, right? So she can come back, and if she wants to space, you can give her option of LARC. But for your exam purpose, remember, you cannot do this procedure. And the next one, Primey, 38 weeks, symptoms of suspicious COVID-19. She has attended maternity hospital in active labor. She has a wish list. At any cost, she wants to have water bath. Remember, she has a COVID-19. Even though it is like respecting her wishes, but because it is going to be dangerous for others, you will not be allowing her to have the birthing pool. Generally, the wishes are respected. However, in this case, you cannot. Okay. And few litigations, common is litigations in gynecology, laparoscopy, internal injury, hysteroscopy, perforation, colposcopy, misdiagnosis, and inadequate sampling, very common. Hysterectomy, ureteric injury, urogyne, mesh-related problems. So these are quite common ones. And incident reporting. Please remember there is a lot of trigger list for incident reporting because it could be maternal, fetal, organizational. However, once you report an incident, the clinical governance lead would look into whether they need to proceed further. For example, if somebody was walking in the hospital corridor and they fell down because there was a water, that is an incident which they would be reporting. However, to do further evaluation like a root cause analysis, if how serious the incident was, somebody fell down and broke their legs and hands, it becomes serious. Then the clinical governance lead would think, okay, there is an incident reporting here, there was a serious harm, let's evaluate further. That's how the whole process goes in. So suggested trigger list, you need to know a couple of things. Shoulder dystocia, obviously, it's a good idea to go through the whole list. I'm only marking the most important thing. blood loss of more than 1,500 mLs, hysterectomy or laparotomy, which was not consented, readmission of the mother, card pH, very important, ABG, like the paired cardboard gas samples, unavailability of a health record, and medication error, and retained swabber instrument. Obviously, these are incident reports which they have to be doing. Any health professional who has come across these issues, they have to report the incident. Okay, but further evaluation, as I mentioned before. The thunderclap route, I mentioned to you this RCOG has two components of OSCEs, which are written and the clinical part, obviously summative. You remember I discussed this first in the first few slides. She's asked a 15-year-old asking for a contraception. Definitely, this is what is your Fraser law. Between 13 to 16, if you feel they have a capacity, they are able to understand the pros and cons, and they are able to communicate, you go ahead. Also, one thing is you need to remember, before you give a contraception, you need to understand the legal age to have sex is 13 years. Anybody less than 13, even though it's a consensual sex, you have to report to the police. 13, more than 13, you can offer contraception, but need to know the age of the boyfriend, whether it's more than 4 years, because you want to avoid the sexual grooming. Second thing, you always encourage her to inform the parents. We know that these young children will still go ahead with or without contraception, which can have a bad effects on future reproductive potential. Okay, remember Fraser for contraception, Gillick competency is for consent. Okay. Women came and requested a reversal of de-infibulation. That is, they are asking for re-infibulation. Obviously, this is FGM, you would refuse. It is illegal to do. Patient have consented for laparoscopic ablation of severe endometriosis, which is X. Surgeon found ovarian mass Y, which adherent to endometriotic lesion and rupture spontaneously. What would you do now? Because during the thing, it has ruptured, and probably they have taken an ablation of ablation consent. And obviously, when there is always a form or a line, the consent form, which talks about any additional procedures required. Okay. So in that case, you would have filled in like probably repair of the injury to the organ or the blood transfusion and things like that. So here you can go ahead and remove both X and Y. Patient with endometriosis and do a consent for diagnostic laparoscopy. Surgeon found ovarian cyst, which is adherent to pelvic wall. Both are for endometriosis, one diagnostic, one therapeutic. So obviously, you will only be doing a diagnostic laparoscopy. You won't do anything with the ovarian cyst because you have not taken the consent. And frequencies, you need to know, guys. This one, sometimes they can ask about what is common, uncommon, the numerical ratios they will be asking. Okay, and what is the primary duty of Caldecott Guardian? Confidentiality issues. How frequently doctors need to be revalidated? 5 years. And this one, what would be the recommended management? 24-week in antenatal clinic. Fear of childbirth, and is asking for elective cesarean section as a mode of delivery, which we call tocophobia. Always explore fears and counsel with a trained personnel. She might have a specific reason why she wanting to ask this. Explore, and if she still wants, obviously will proceed in the best interest. The next one, what should you do? 32-year-old primee had a slow progress of labor for past 10 hours, 8 centimeters dilated, deflextropy, CTG shows repeated late deceleration, has been classified as pathological. Baby is not doing good. She has developed pyrexia of 38.3, for which you have administered antibiotics. You suggest emergency CS. She declines the same and wants to continue for vaginal birth because she wants the natural birth. Obviously, we know this answer. Respect her choice. Continue monitoring. Document. Okay. Because she is going towards sepsis. We don't know what will happen. So you need to know about that. Okay, guys, fantastic. That finishes our wrap with all of rapid fire and thunderclap rounds. I have put in all the concepts with the questions. Hope this helps. Embrace your awesomeness. Remember, you have been fantastic. You are doing good. You will be just awesome. All the best, and subscribe our YouTube channel and like the video, and don't forget to leave the comments. God bless, guys, and stay blessed. Bye-bye.